Hopefully everyone can hear me. Thank you for joining us for the Clinical Trials Methodology Course 2017 webinar series. Our webinar today is what you need to know before talking to your statistician about sample size, and it will be presented by Dr. Sharon Yeatts. The usual housekeeping items before we get started. Everyone except our speaker will be muted to prevent feedback during the presentation. But please use the chat box to type any questions you might have for Dr. Yeatts. If you're interested in CMEs, you must complete an evaluation form, and we'll provide details at the end of the webinar. So it's my pleasure to introduce Dr. Yeatts. She's an associate professor of biostatistics at the Medical University of South Carolina, where she's the PI of the Statistics and Data Management Center for the phase 1 and 2 trials of deferoxamine in ICH, and the PI of the National Data Management Center for Diffuse 3, which is a clinical trial using an adaptive design to assess the efficacy of endovascular therapy following imaging evaluation in stroke. Dr. Yeatts was the primary unblinded statistician for the IMS and PROTECT phase 3 clinical trials. As a co-investigator on these grants, she was responsible for the statistical monitoring of data and the implementation of interim and final efficacy and safety analyses. Dr. Yeatts serves on DSMVs and as a grant reviewer for several funding agencies. Her primary research interests include the development and implementation of efficient early phase trial designs and novel trial outcomes. So thank you very much, Dr. Yeatts, for joining us today.
Thanks. I see rather a lot of people, more than I expected for a Friday at noon. So thank you all for coming. And Sam and I talked about this yesterday. I'm going to try and keep an eye on the chat box. So if you have questions while we're going through the talk today, please feel free to ask them. Or you can hold them until the end. Either way should be fine. Some brief disclosures. I do receive consultant fees from Genentech for my role on the steering committee of the PRISMS trial, but that's not going to have anything to do with what I'm going to talk to you about today. I'm not going to talk about anything that involves unlabeled use of commercial products or any unapproved investigational use. Okay, and now Sam is going to take over the screen and she's going to play a video for you. We're going to start off with something a little bit lighthearted, because what I hope you'll get from our talk today is that you don't want your conversation to go the way this does. So let's listen.
And I need to know how many patients I need. I think I only need 3 patients.
Okay, what kind of study is it?
I'm doing a lab study. Cannot just use 3 patients.
That depends. What are you trying to show?
We always use 3 patients.
Okay, what are you trying to show?
I'm trying to show that drug A and drug B are better than only drug A.
How are you measuring if it is better?
We are looking at apoptosis. Can we just use 3 patients?
What kind of measure of apoptosis? Do you know how variable the measure is?
We always use 3 patients. That is what we have published before.
3 patients per group or in total?
Yes.
Okay, let's try something different. What type of measure are you using? And is this an in vitro study? An in vivo mouse study?
It is an in vitro study of patient samples, and we are looking at measures of apoptosis after treatment with drug A and drug B versus drug A and control, and drug B alone.
Oh, how many groups are you analyzing altogether then?
My grant is due tomorrow. I just need to know if I can just use 3 patients per group.
Okay, well, you probably should have come to me earlier for help with this.
All I need you to do is tell me that 3 patients are okay.
So, it is not that easy. Your marker for apoptosis may have a large amount of variability associated with it that could make it difficult to ascertain differences based only on 3 patients per group. It also depends on what kind of outcomes you are looking at. Are you looking at normalized changes in expression levels from baseline? 3 patients may not be sufficient to detect differences in these expression levels between the different treatment groups.
I do not understand.
I'm saying that you may need more than 3 patients per group, but that I need more information to determine that.
The serine protease granzyme B is made in cytotoxic lymphocytes, where it is inactive due to the low pH of the storage granules. It is measured immediately upon delivery into target cell cytoplasms, where the pH is neutral. This is followed by cleavage of phase 3 by granzyme B in the target cell cytoplasm and the subsequent induction of apoptosis. All proteolytic events can be quantitated at the live single-cell level by flow cytometry and imaged by confocal microscopy.
I understand very little of what you just said. Maybe we should talk more about this.
I just need to know if 3 patients are enough. My grant is due tomorrow.
We will need to meet to better understand this before we can determine the appropriate sample size.
I can put you on my grant for 0.5% FTE. You can design and analyze the data later.
Do you really think that is enough to do the work?
Well, it may be less if it is awarded and the budget is cut.
Please go away.
Okay, so okay, so some of you are laughing in the chat box, so I appreciate that. I really love that cartoon because all of the statistical colleagues have had a conversation go like that at least once in their career. And on a fairly regular basis, we have parts of that conversation occur when we meet with new collaborators. So hopefully what you'll get from this talk today is at least a sense as to what questions your statistical collaborator might ask when you have that first meeting, and a sense that that collaboration really needs to be sort of a process where you bring each other up to speed. It's unlikely to be a scenario where you meet with someone and right away they know everything about your disease area, your outcome variables, the sources of variability that need to be addressed. You might get lucky and find someone like that right from the beginning, but chances are it's going to be a learning process as you figure out how to work with each other, how to understand the language each other is speaking. So just keep that in mind. Okay, a little bit of a disclaimer before we get started. I had to focus this talk on something. We could talk for an entire semester about all of the possible designs that are available and how you would choose a sample size for each of those. But I only have an hour, and it's an hour on a Friday. So I understand that I have to give you as much as I can give you and do it in a fairly focused way. So this talk is geared towards the design of a superiority trial. And what I mean by that is not necessarily a phase 3 definitive clinical trial, but any 2-arm randomized trial where your intention is to show that one treatment is better than the other with regard to whatever your primary outcome is. And I'm assuming that the deliverable that you're interested in is the p-value from a hypothesis test. Okay, there are many other trial designs, many of which would be as important for you at this stage of your career, if not more than the superiority trial. You might be interested in establishing something other than superiority. You might be interested in using a futility design to weed out ineffective therapy, or a non-inferiority design to show that your intervention is no worse than what is currently the standard of care. The end game that you're interested in might be something other than a hypothesis test. Hypothesis test does not have to be the bottom line deliverable from a clinical research design. You might be interested in estimating a control rate with some level of precision, or selecting the optimal dose that you want to move forward for future testing, or just finding a range of active doses for your particular intervention. And in those cases, some of the things that we're going to talk about here are going to be more or less or not relevant at all. But what we'll cover here is going to give you sort of the basics of how that conversation is going to need to go and what things do you need to keep in mind. Okay, so the first thing I want to cover very briefly is why do we worry about power and sample size? And the answer is more than just because grant review expects it, right? We worry about power and sample size because we want to provide some level of assurance that the trial has a reasonable probability of being conclusive. If we are not going to be able to answer the question that we're asking, then there's no reason to expend the resources that are required to run a clinical trial. So we want to figure out the sample size that is necessary so the resources that we have, which are limited, can be efficiently allocated. And resources doesn't necessarily have to be just the money at the funding agency. It's the human collateral, right, that you have at your institution that's required. Sorry, Mona is asking, is anyone else's sound breaking up? Am I not coming through okay? Okay, it sounds like it's okay for most folks. I don't know, Sam, maybe you have some suggestions to help Mona?
You sound okay to me. Mona, if you want to adjust your volume. Or maybe log out and log back in. Or if you have multiple programs running at the same time, they may be taking up bandwidth, so you can stop the other programs that you have open on your laptop.
Thanks, Sam. So the resources we have available could be the personnel effort that we have available at our institution to actually conduct the clinical trial, but it's also the patients that we have available in the population at our institution, at other sites that we might be interested in. And of course, there are some ethical issues with allocating those resources. So if the study is too big and we could have answered our question with fewer subjects, that means two things. One, we're taking money away from other questions that could be answered, but we're also needlessly exposing subjects, right? So if we have a study that is intended to roll 200 patients, but we only needed 100 to answer the question, those 100 subjects extra are not only exposed to your particular intervention when really we already know the answer to the question, but that's also taking those 100 subjects out of circulation for other investigators to access for their studies. On the other hand, a study that's too small means we could be making the wrong decision. And so again, I would argue that that's unnecessary experimentation. If, because of the power that we have associated with our sample size, we have no better than a 50-50 chance of getting the right answer, then we're not using our resources very well. Okay, so what are the key factors that are necessary to determine the sample size? We're going to talk about all of these today. We're going to start by talking about the level of significance alpha, because it tends to be what most people are familiar with. And it's easy to start there because it's pre-specified at the start of the study. And then we're going to talk about the target power and how those two variables interact with each other. We're going to talk a little bit about the minimum scientifically important difference and how that impacts our sample size calculation. And then we're going to talk about the variability in the response, both how we measure it and how it impacts the sample size calculation. And then we're going to talk very briefly about the experimental design. And again, there's lots of sort of nuances to some of these topics, especially the experimental design, that unfortunately we just don't have the time to cover here. So first things first, what is the research question? Your research question should be stated in the form of testable hypotheses. I don't know, in my small group, we just finished the meeting where we reviewed the objective and hypotheses statements. And so the folks who were in our group have already sort of heard my bent on this. But when I read the research hypothesis, the research question, I really like for that statement to tell me everything that I need to know in order to figure out how the data should be analyzed. And that's going to lead me to how many subjects do I need and what in order to achieve a certain power. So it's very easy to state the research question in terms of in language that your clinical colleagues will understand. But you want to make sure to provide enough specifics that the statistician can start thinking about what does that mean in terms of what I need to know to move forward. So you want to be clear about what is the population, what response variable are you using. So don't just say, I want to show that drug A is better than drug B. You want to show that drug A is better than drug B with respect to whatever clinical outcome variable you're using. What are you comparing? Are you comparing drug A to drug B, drug A to control? In the cartoon, we heard two different, there were two drugs and a control, and there was some suggestion that drug A and drug B were going to be tested together. So you want to make sure that all of that information is there. And at what time point are you making this assessment? In a lot of clinical trials, we collect data longitudinally, although we don't necessarily use it in that way. So you want to be clear. Are you evaluating the time course over, say, a 3-month period? Or are you just looking for differences at the 3-month time point? Okay. So in statistics, we really think about the world as being consistent with only 2 states of nature. And we reflect those 2 states of nature in the 2 hypotheses that we state. So I start by talking about the alternative hypothesis because I find that that's the easiest for investigators to state clearly. Because the alternative hypothesis is really the statement you want to be able to conclude, right? You want to be able to say that your intervention affects outcome. So that's very easy. The null hypothesis is the converse of that. So if your alternative is that the intervention affects outcome, the null is that actually it does not. And the null hypothesis then is the statement that we hope to contradict with the data. And so this is, it's a little bit backwards, and if you're thinking about it for the first time, the alternative is what you want to conclude, but from a frequentist statistical perspective, the null hypothesis is where we sort of operate. Okay. And it turns out that statistics is basically the simplest form of the scientific process. It's based on proof by contradiction. Okay, so you conceptualize nature as being in one state or the other. Either the null hypothesis is true or the alternative hypothesis is true. One statement I probably should have made on the earlier slide is that those hypotheses, when you state them, have to be both mutually exclusive, so they can't both be true, and they have to be comprehensive, which means there can't be some third explanation that's not covered by the statement of those 2 hypotheses. So you conceptualize nature as being in one state or the other. Either the null is true or the alternative is true. And then you collect data from the real world. And if the data clearly contradict the null, then you trust the data and conclude that the alternative must be true. And if random noise or measurement error or chance can account for those observations under the assumption that there is nothing going on, then there's really no need to go with the more complicated explanation, right? As scientists, our preference is to believe the simplest explanation as the one that's most likely to be true. So again, if the data that we've observed are consistent, for lack of a better word, with what we would expect under the null hypothesis, then we can't go with the alternative, the more complicated. And that's basically what we're doing when we're conducting a statistical hypothesis test. So because there are 2 statistical hypotheses and they have to be mutually exclusive and comprehensive, that means the null hypothesis, there's only 2 possibilities for its truth, okay? It's either true or it's false, and we can only make 2 decisions. We can either reject the null because the evidence that we've collected clearly contradicts it, or we fail to reject the null because what we've observed is consistent with what we would expect, okay? So what we have is this 2x2 contingency table that you see on the slide here. And with this 2 table, you see 4 possible outcomes as the result of our experiment. So I'm not sure, can you see, I don't know if you can see my arrows, but there are 2 correct decisions, right? So, and 2 errors. And we're going to talk about each of those. And what we're going to try to do when we set up a statistical hypothesis test is to minimize the likelihood that we make one of those errors and maximize, or at least achieve a target likelihood that we are going to make a correct decision in rejecting our null. Okay, so if the null hypothesis is false, which means that your intervention works, and you reject the null hypothesis, so you can conclude that the intervention works, that's a correct decision, right? It's a wonderful thing. You write papers, you present results at national meetings. It's a fabulous thing. The other correct decision is not quite as exciting, but it is still a correct decision. Sorry, Sam just sent me an email, a message. I'm trying to see what it says. You should have a pointer at the top right, down pointing arrow. Ah, got it. Okay, so we were talking about this. Thank you, Sam. We were talking about this correct decision over here. Okay, that's the exciting one. The other option for a correct decision, although it's not very exciting, is the one over here. Okay, so the null hypothesis is true. Your intervention doesn't impact outcomes at all, and you fail to reject it. Okay, it's not very exciting, right? There is some publication bias, although perhaps it's getting better, but it is still a correct decision. The errors that we can see in this table are those that we are going to try to minimize by setting up our statistical design correctly. So the first one we're going to talk about is this error here, okay, the type 1 error. So this is essentially a false positive. If the null hypothesis is true, meaning the intervention doesn't impact outcome, but somehow your data suggests that it does, then we've made a type 1 error. And we are going to restrict the likelihood that that happens by setting what we refer to as the level of significance, or the alpha level, to something very small, okay? Often you will have heard that the alpha level should be 0.05. There's nothing magic about that, and I'll try to make that argument in just a minute, but you want to set it to be something small. The other error we refer to as a type 2 error. This is the situation in which the null hypothesis is false, so your intervention actually does work, but your data fail to allow you to conclude that, all right? So we restrict the likelihood of making a type 2 error in much the same way as we restrict the likelihood of making a type 1 error. So for the type 1 error, we restrict the alpha level. For the type 2 error, what we do is we acknowledge that if the null hypothesis is false, right? So if the null hypothesis is false, and there's only 2 decisions, then this correct decision and this error are the only 2 possibilities, right? And if we say the probability of making a type 2 error is beta, right, then the power of our study must be 1 minus that, because those are the only 2 options in that column, okay? So we don't often think about restricting beta, but we do that by setting the power to be something high, okay? Okay, so the level of significance alpha, we pre-specify it in the trial design, and I'm going to argue that it should be based on your own willingness, or the community's willingness, let's say, to accept a false positive based on what the consequences of that error are in your particular scenario, okay? So think about the interpretation for the level of significance. The level of significance, if we set it at 0.05, let's say, what that means is that even if the null hypothesis is true, you're going to conclude the alternative 5% of the time, okay? Again, 5% is not a magic number. It is very commonly used. There's nothing magical about it. It doesn't have these amazing statistical properties. But I can, at least I can, easily think about situations in which maybe 5% is not quite does not quite reflect our willingness to make that error, okay? Imagine a situation in which you are testing an intervention related to a more balanced diet, okay? Or increasing moderate exercise from 3 days a week to 5 days a week or something along those lines, right? So, and let's say our outcome is mortality, okay? Even if achieving a balanced diet or increasing our moderate exercise does not actually impact mortality in some clinically meaningful way, in my mind at least, it's hard to imagine that there is a real downside to suggesting that people eat better, right? Or that people exercise more. So in that case, when there's not really a downside to making that false positive, that claim that you actually should follow this intervention, then 5% maybe, again, it's not a magic number. Maybe you could go with 10%, right? On the other hand, let's say that you are evaluating a surgical intervention when the current standard of care is medical management. Okay, so the medical management regimen has a very benign side effect profile. It's well tolerated, and you're testing a surgical intervention which has very real risks associated with the surgery. In that case, in order for you to recommend that people go through this extra risk and likely this extra cost that's associated with the surgery over and above the medical management, maybe a 5% false positive rate is too high to accept that risk for future patients. Maybe you want it to be something smaller. So I'm not saying you shouldn't choose 0.05, but I'm saying you can think through your scenario and choose something else if that seems more appropriate. Okay, so for those of you who haven't had stats in a bazillion years, I'm just going to show you what I mean by the level of significance, because I'm not showing any formulas at all in this talk. We're going to sort of intuit everything that I'm going to say by looking at pictures, because I think that's easier. So if you remember way back to your stats class, this is a normal shaped curve, and it would represent what we would expect from our test statistic if there's nothing going on, right? So you can see Z is the test statistic, say, from a 2-sample Z-test for comparing proportions. And it's centered at 0 because the two groups are identical. If we specify a one-sided alpha of 0.1, then this shaded region here is our rejection region. So any test statistic in this shaded region would be evidence in support of our alternative hypothesis, okay? Because the shaded region represents an area under the curve of 0.1, okay? If we instead decrease that level of significance from 0.1 to 0.05, we decrease the shaded region, the area under the curve, and so we make it harder, right, to declare in favor of our alternative. And one more, all the way down to 0.01. So you can see how that shaded region diminishes as we change the level of significance. Okay, and this graph here then just shows you what the difference is between those 3 levels, all on the same graph. I'm going to show you in a minute why that's important. Power is probably one of the first things you have to think about when you're deciding what your sample size is going to be for a study. And so it's important, again, to understand what the interpretation of that power is, because, again, 80% is very common, 85% is very common, but there's nothing magical about those two numbers either. The power represents the probability that your test, your statistical test, is going to reject the null when it's false, right? So it's the likelihood that you make that correct decision that the intervention works. What I want to point out to you is, and we're going to talk about this a little bit more, is that the power calculation is specific to a given value under the alternative hypothesis. So the interpretation is, for a given value under the alternative, we're going to reject the null in favor of the alternative 1 minus beta times 100% of the time. Okay, so you should be skeptical anytime you hear a blanket statement about power that's not tied to a particular effect size. And when you have that conversation with your statistical colleagues, one of their first questions is going to be, when you say, I want an 80% power for my study, they're going to say, at what effect size? Because we can come up with 80% power for anything given a fixed sample size, but it has to be something that's clinically relevant. And we'll talk about that in a minute as well. Okay, so how does the level of significance impact the power? And again, I told you we're going to do this all graphically, so hopefully this will make some sense. So what I have now is two normal curves, right? So the normal curve on the left is basically what I just showed you. It's the curve that you would expect under the null hypothesis. The curve on the right is what you would expect for a fixed value under the alternative. So it looks like it's centered at about 2. Okay. When I add the shaded region that we just saw, so if the level of significance is 0.1, for this particular alternative, you see the shaded region, right? More than half of the alternative curve is covered by that particular level of significance. Okay. As I decrease the level of significance, remember I decrease the shaded region under the null, I'm also going to decrease that shaded region under the alternative, which means here, if I picked a value of, say, if I observed a value of 2, right, that would be very easy. It was clearly in the rejection region. It's well covered by the power curve under the alternative. But again, my shaded region gets smaller. And so eventually my 2 here, which is clearly in the rejection, which was clearly in the rejection region for larger levels of significance, is no longer. And the power that's associated with that is now less than half of what it was. Okay, so it does, changing the level of significance has an impact on what the power is going to be. And so that's why I say you have to pre-specify it up front, and it's not sufficient just to pre-specify it before you analyze the data. You have to pre-specify it at the design stage so that the alpha level you want to use is taken into consideration in that power calculation. Okay, and again, here's just that comparison. So you can see how the coverage probability, the shaded region under the alternative curve, is impacted by changes to the level of significance. I'm not sure if I said that very clearly, but hopefully y'all get the gist. Okay, so on the previous slide, what I showed you was that this was for a fixed alternative, right? This alternative curve here is centered at 2. But in reality, you have to determine where that alternative curve should be centered, right? It's a clinical question, not a statistical one. In many cases, when we meet with collaborators, they come with the effect size that was observed in a pilot study, or the effect size that was observed in the literature for some other intervention that worked. Most of my statistical colleagues would make the argument, again, that's not a statistical question, it's a clinical question, and it should be that your study is powered for the minimum scientifically important difference. And by definition, then, that is the smallest difference which would mandate, in the absence of serious side effects or excessive cost, a change in scientific practice and understanding. Okay, we do have a rule of thumb, of course. The larger the difference that you're trying to detect, the smaller the sample size. It's a little simplistic, which we'll see in a minute. But again, we're going to do this. We're going to do this graphically. So this is the curve under the null. Okay, it looks like my one-sided alpha level here is probably 0.05 or so. Okay. And now I'm showing you an alternative which is shifted by only 1 unit, right? And you can see, again, if we extend the coverage probability under the null so that it is also reflected under the alternative, you see we don't have a very good chance of being able to distinguish between these two curves. They overlap so much that it's hard to tell them apart. Okay. As I shift that curve further and further, right? So now it's centered at 2, which is what we saw earlier. Now it's shifted at 3. And you can see that any value that falls within the rejection region under the null is clearly has a better chance of being associated with the alternative hypothesis, right? So again, this idea that the larger the difference we see, or we're trying to see, the smaller the sample size that's required, is pretty accurate. It does ignore the contribution of variability. And so we do have to take that into account. And again, I'll show you a graph for that in just a minute. First, we need to talk about what do we mean by variability. We need to think about whether the outcome is continuous or categorical. So if our outcome is continuous, then what we mean is that we need an estimate of the standard deviation or the variance that's associated with our outcome measure. If instead our outcome measure is binary, then we need an estimate of the control rate, okay, the rate of good outcome or mortality or whatever under the control arm. So why is that important? So again, I'm trying to use graphics here to help you intuit how all of these pieces play together. So here we have the curve under the null. Okay, the curve under the null is over here, centered at 0. Here's a curve under an alternative, centered at about 3, right? And you can see that there's not a lot of overlap, right? So if you observe a value over here at about 2, you're more likely to believe that the data came from the alternative than you are to believe that it came from the null, right? But what happens if the variation that we have expected under these two curves is not as we expected? Okay, what happens if, so these are normal curves with a standard deviation of 1, let's say. What if instead they have a standard deviation of 2 or 3? Okay, the curves stay centered at the same place, but the width of them gets bigger. And now we don't have anywhere near the nice distinction between the two distributions that we had previously. And so whereas before we felt pretty confident if we saw a value of 2, that was evidence in favor of our alternative, now we're not so sure, right? So again, that variation plays an important role. Are there questions about that before I go on? Otherwise, we'll talk about an example for a few minutes. Okay, I don't see anyone typing feverishly, so we're going to go on. But if you have questions, please feel free to ask. Okay, so we are going to talk about an example mainly so that I can show you in the real world how variability impacts what you're trying to do, okay? Because I know it's sort of talking about the graphics, it's a little abstract. You don't really have a sense as to how big a difference it can make if your assumptions are incorrect. So this is an example of a phase 2 clinical trial that we are actually working to develop now. In subjects with acute ICH. The intervention that we're testing is intended to impact health-related quality of life. Okay, so that's our primary outcome is going to be quality of life as assessed by the NeuroQual. And I think we're using the cognition subscore. I can't quite remember, but you get a nice T-score that's associated with it. It's a normally distributed outcome. It has fairly well-known properties. And so for the purpose of example, I'm assuming that the minimum clinically important difference for this particular outcome measure is 0.5 units. All right, and I've given you a graph here that shows the sample size on the x-axis, the power on the y-axis. And our initial guess is that the standard deviation should be 1 associated with this outcome. So what we're really saying is we're targeting a standardized effect size of 0.5, right? 0.5 units over the standard deviation. So that is represented by the blue curve here. So you can see that if you want to achieve 80% power for detecting that minimum clinically important difference of 0.5 units, you need less than 150 patients to conduct this clinical trial, okay? If you're wrong, if we're wrong, since we're doing this, if we're wrong and the standard deviation is actually 1.5 units, then instead of a standardized effect size of 0.5, we're talking about a standardized effect size of 0.33, which is a fairly dramatic reduction, right? What we wind up with instead is this orange curve. So if we want 80% power, then we need almost 300 subjects to test the same hypothesis for the same clinically important difference. And if we're wrong in the other direction, okay, so if the standard deviation is actually 0.5, then what we're targeting is a huge standardized effect size. We're operating under this red curve, so that really we needed less than 50 subjects to conduct the same hypothesis test with the same power. So it is sort of an abstract concept that the variance matters, but in terms of designing your study, it does matter, and it can matter rather dramatically. So when you're thinking about what information you need to bring to the table, I would think through what you have available, either from pilot studies or from the literature related to your outcome. And if you can, come to the table with a plausible range of values for the variation so that you can really say, if my assumption is wrong, in how much trouble am I going to be? Okay, let's say for the same study, same intervention, what we really want to do is not to impact quality of life, but to impact functional independence. Okay, so we're going to define it as a modified Rankin scale score of 0 to 2. It's a pretty standard definition. And we're assuming that the minimum clinically important difference in terms of the good outcome rate is an absolute difference of 10%. Okay, so if the control rate achieves 50% good outcomes, let's say, then we're hoping to get to 60% under the intervention. So now what we talk about what we mean when we're talking about variability is the proportion under the control condition, okay? So I'm gonna start with a control proportion of 0.4. Actually, let me do it the other way. I'm gonna start with a control proportion of 0.1, which means what I'm trying to target is a difference between 10% and 20% in terms of functional independence. And that is this blue curve over here. So in order to achieve 80% power, I need 400 patients maybe. If my control proportion is 20% instead of 10, then I'm operating under this orange curve here. Okay, so now I need closer to 600 patients for the same power, same absolute difference. Over here, the green curve represents a control proportion of 30%, and I'm now up at 700, 750 patients. And if I'm up to here, a control proportion of 40%, then now we're talking about roughly 800 patients, again, to test the same hypothesis with the same level of power. Now, I told you that this is a phase 2 clinical study, right? And so now I'm talking about sample sizes of 800 patients, and you should all be sort of laughing to yourselves because it's not possible, right? So we're not going to talk too much about the other options, but I do want to point out, and this has come up already in my small group, if you try to design a study this way, okay, and you find out that the sample size is too large, and so you say, well, I really needed 800 patients, but I just can't get it. I'm going to go with 200 patients and just accept the consequences. The consequence is that you will get dinged rather severely for trying to conduct an underpowered phase 3 study, okay? There are some ways that you can rethink your hypothesis to make it more feasible, okay? So I'm going to talk very briefly about switching from that superiority hypothesis that we just talked about to a futility hypothesis. So same phase 2 clinical trial in subjects with ICH. What if instead of trying to establish that there was evidence of a difference between the two arms, you know, we're looking for that proof of concept so we can move it to phase 3. What if instead of looking for proof of concept to move it to phase 3, or proof of efficacy, or signal of efficacy, however you want to word it, in order to move it to phase 3, what if you rethink the hypothesis and say, what if instead we try to show that the effect is less than we would need to see? What if we show that it's less than that minimum clinically important difference? And if we can show with some certainty that it is less than the minimum clinically important difference, then there's no reason to move to phase 3, okay? And that's basically what the futility design is doing. And so again, here on the left-hand side, what we have is the curve that we just looked at, and the colors don't match up, so I do apologize for that. On the right-hand side, we have the same scenarios, but under the futility design. So we're trying to show that the effect of the intervention is less than the absolute 10% that we would like to see. And under the control proportion of 0.1, we have this orange curve. Okay, so we need less than right about 200 patients to test it, the futility hypothesis here, whereas here we needed about 400 patients to test for a difference between the two. Okay, and you can see the same thing here. For a control proportion of 0.2, we're operating under this red curve. We need maybe 300 patients. Here, for 80% power, we needed 600 patients. Okay, so you can see all of these, we need fewer than 500 patients regardless of what our control proportion is in the futility case, whereas here we're hitting at 600 or more under most control proportions that we might consider. Okay, it's not going to work for every scenario. I mean, it's not suitable for every scenario, but it is something that you can think about to help you as you're working through your designs. Okay, so before you ask about sample size, when you have that meeting for the first time with your statistical collaborator, be prepared to talk about the level of significance, the power, the expected variability in the response. I think I said this already, a range of plausible values is better if you can come up with a range. You want to talk about what the minimum scientifically important difference is. If the sample size for that proves to make the trial not feasible, then you can play with it a little bit and see if you can get something that is still justifiable. And you want to talk about the experimental design. Again, there are some experimental design considerations that can help you, one of which we just talked about, rethinking your hypotheses. You can consider whether you really need a concurrent control arm or whether you can make use of historical controls instead. If you can, that can give you a substantial sample size savings, although it's not always appropriate, and so you'll need to think about that. Are there multiple questions which can be answered in the same design? Sometimes a larger sample size is more palatable if you can say, but I'm answering 2 questions instead of just 1, and so you might be able to think about that. You can also think about whether a hypothesis test is actually the best way to achieve your goal, right? So if your intention is to select a dose, then probably hypothesis testing to do that is not your best approach, because it's going to be hard for you to declare a difference between doses that are active, right? So the difference between 2 active doses is likely to be smaller than the difference between either of those active doses and control. So you can think about using selection to guide your design instead of hypothesis testing. And I do want you to keep in mind that the sample size calculation depends on the method of analysis. So sort of all of this needs to be worked out before you can really have a truly informative sample size calculation. You do need to justify the sample size very clearly. How many subjects do you need? Is that sample size adequate? How is the sample size determined? Do you need more? And can we answer questions with fewer? There is a question was just posted to chat. Is there a rule for the fraction or percentage of sample size you would use for a pilot study sample size? I don't have a rule of thumb for either a fraction or a percentage. I would suggest that it really depends on what the aim of the pilot study is. So if the aim of the pilot study is to estimate the control rate, then you should be trying to come up with the sample size that's needed to do that with some level of precision. If the aim of the pilot study is to demonstrate feasibility, then you need to come up with what the definition of feasible is and tailor the sample size calculation to that aim. So I don't feel like there's a rule of thumb because there's too many things that you could be doing with that pilot study. In terms of keeping it small, you can study a continuous rather than a binary outcome. Sometimes that can be helpful. You can study a surrogate outcome where the effect is large. And during the in-person course, I think if it's not a webinar, I think it's at the in-person course, there will be a talk usually about surrogate outcomes or biomarker outcomes, things like that, that you know to be associated with the clinical outcome that you will eventually be targeting. There are two ways that we can go through this process when you meet with your statistical collaborator. I prefer the first way, which is that you come to the meeting with me and you talk to me about what the difference is you want to detect. You talk to me about the variability. You talk to me about your target power, and then we calculate a sample size. And that's, that's your ideal sample size. In basic science, it's often the case we do it backwards because we have more limited resources. So a collaborator might come to me with the sample size that's available, the target power, and the variability, and then we calculate the detectable difference. Either way is possible. It's not that either one of them is wrong, but I think it's helpful for folks to have in their mind what the ideal sample size is, so you know really how far off you are, right? So if your ideal sample size is 150 and you think you can only access 140, okay, you're in the ballpark. Maybe the power is not going to be exactly what you thought it should be. Maybe the effect size is going to be just a smidge bigger. You can accept and think through what those consequences are. If your ideal sample size is 1,000 and you come to me and when we calculate the sample size, you tell me all you have is 100. Again, I think it's helpful for you to know how far out of the ballpark are you, so we can start thinking about how can we answer this question in a more efficient manner, if it's possible. Sometimes it's not. There's lots of sample size software available to you. I've listed some links for freeware here. I'm sorry, I forgot to test the links and make sure they still work, but there's lots of freeware. Statistical collaborators will have software purchased that's available to them. SAS also does it, although I don't use SAS for sample size, but if you use it, that's an option as well. But again, your statistical collaborators are going to have lots of options available. I did not, these are not my words, but this language is very clearly on the front of the Iowa website for their sample size software, and I just thought I would repeat it here. So the author said, I received quite a few questions that start with something like this. I'm not much of a stats person, but I tried XYZ. Am I doing it right? And he said, please compare this with, I don't know much about heart surgery, but my wife is suffering from XYZ and I plan to operate. Can you advise me? Okay. A lot of the freeware, especially that's available is point and click. You can eventually find something that will that your inputs will work in and it will get you a sample size, but it's not guaranteed unless you really understand the methodology that you're going to be using, that sample size will be meaningful at the end of the day. So again, I would suggest that you find a statistical collaborator at your institution or at a nearby institution. It can be a very mutually beneficial experience, especially if you find someone who is at a similar level in terms of their academic appointment. So you can sort of grow into the collaboration together. In some institutions, it costs money, but also some institutions, especially those with CTSAs, have consulting services available, either at reduced cost or initially for free to help with grant writing. So please do sort of look around. And if you need, you know, one of the things we can help you do with this course is to find someone if you're having trouble. One more thing we haven't really talked about that is going to come up, if not in the first conversation with your collaborator, at a later one, are some of the logistics of running your clinical trial. So you want to talk about what the anticipated recruitment rate is. It's going to be incredibly important for time to event outcomes. It's going to be very important if you're talking about adaptive designs. So you need to understand how long is it going to take you to recruit patients either at your site or across all of your sites. You need to have an understanding of what the crossover rate is and what you want to do with those patients who have crossed over. And assessment of protocol non-adherence, because it can impact the treatment effect, it can dilute it, and so you might need to increase your sample size. And the same is true for loss to follow-up and consent withdrawals. We would typically increase the sample size to account for that as well. So all of those things you'll want to be thinking about. Okay, that's all I have to talk to you about today. Are there questions? I'm happy to take some. I see someone's typing. Oh, but no question. You're welcome. Like I said, I'm happy to take questions if you have them now. If you think about it later and you want to shoot me an email, that's fine too. I think my email was on the first slide. I am literally about to walk out the door on vacation, so I probably won't respond to you for about a week, but I'm happy to answer questions that way as well. Okay. And if there are no questions, then I just thank everyone for coming. And I think Sam has some housekeeping stuff.
Yes, so thank you, Dr. Yeatts. Thank you for a great talk, and to everybody for joining. First thing is, if you would like CMEs, please complete the evaluation form. The link is there in the web links box. If you click on the link and then click Browse to, it'll take you directly to the evaluation. It really helps us to get feedback so that we can improve the series. So please do that. So today's webinar is eligible for 1 AMA PRA Category 1 credit, and we'll provide all the CMEs at the end of the series in November. And today's webinar and slides will be posted to the website. Usually we do that within a week, so please check the website. And then our next webinar will be on June 23rd at noon Eastern Time. And the topic will be creating a budget for a single site clinical trial. So please join us on the 23rd, and thank you, everyone. Have a great weekend.
Thank you, Sam.